So because heart failure with preserved ejection fraction is one entity which has been very, very difficult to control for any cardiologist. It also carries a very high mortality. It has a lot of other comorbidities which are not seen with heart failure with reduced EF, and it is a kind of a nightmare to treat actually. But we are lucky in around last 4 to 5 years we have now two group of drugs, I would say, which have shown some promise. So most important drug have been ARNI. So once the results of PARADIGM-HF came, there was a lot of enthusiasm regarding the PARAGON trial, we all know. But the PARAGON came and initially it was rejected actually, and it did not show benefit in patients. It was thought that it did not show benefits in heart failure with reserved EF. But when it was very carefully studied for patients who had an ejection fraction of around 57, till around 57 or 60%, not beyond that, it showed a clear benefit. So in PARAGON-HF, we were talking of patients who were having EF of less than 40. So here we can cater to patients between 40 and 60, maybe around 57 is the cutoff, but even up to 60%, I would say 40 to 60% patients also. So most of our heart failure patients will fall in that category. Very limited number of patients go beyond that. Maybe we can avoid in those patients, but ARNI fares very well in patients who have an ejection fraction of around 57 to even 60%. So we can give in those patients also, and now the US FDA has also given approval for same. So we know that heart failure with preserved ejection fraction, that is HFpEF, it has a lot of other factors which is not there, lot of non-cardiac factors which contributes to the development of heart failure with preserved ejection fraction. And all previous trials, very important trials like CHARM preserved, PEP-CHF, iPreserve, top cats of ARBs, of ACE inhibitors, of spironolactone also top cat, they had failed to show any benefit in mortality outcomes or even improvement in quality symptoms also. Rarely it showed benefit in heart failure with preserved ejection fraction. So we look at clinical outcomes in patients with heart failure with preserved EF and reduced EF, and here we can see that observational studies suggest similar clinical outcomes. So both these conditions are almost similarly serious. They have almost similar mortality ratios, but there is no important drugs like beta blockers or mineralocorticoid receptor antagonists or ACE inhibitors which actually showed benefit in heart failure with preserved EF. But ARNI has come as a lifeline, I would say, and the PARAMOUNT trial results have clearly shown that improvement is observed with ARNI even in HFpEF patients. And with regards to heart failure hospitalizations, there is a definite reduction in PARAGON heart failure trial when given ARNI as compared to valsartan in PARAGON-HF. Here the comparison was made with an ARB, and significant heterogeneity, and we can see the forest graph mostly in favor of the interactions. And PARAGON-HF primary composite endpoint, we can see again the overall treatment EF quartiles are well matched, and EF cutoff, as we have told previously in the PARAGON trial, was 57%. So this is the forest chart comparing the comparator, the valsartan and ARNI, that is sacubitril valsartan combination, and it clearly is favoring. We can see up to 50 to 60% of the ejection fraction, it is favoring sacubitril valsartan or ARNI combination. Beyond 60%, it is not favoring. So that is what we say in heart failure patients. Now, even between 40 to 60%, we can say that ARNI is definitely one of the drugs which can be given.